G'day guys, my name is Ben and welcome back to Primary Survey. I'm going to run you through an OSCE case today. More specifically, I'm going to run you through one of the tutorial cases. I literally just got the tutorial cases online today. They should guide you through a whole case, basically. So you've got nausea vomiting, which is a basic sort of case. Your goal is non-transport, but again, being AI, you can do whatever. You may end up transporting them. No points off if you do. Chest pain, it's cardiac chest pain with no ECG changes, mostly because I don't want to have to go down that STEMI pathway for a tutorial that's a bit intense. And then also we've got a motorcycle versus car trauma. Today, right now, we're going to go through nausea vomiting. After this, I'm going to go through the other one. The chest pain. So we're called to a sick person, alert, nausea, vomiting, gastroenteritis in Peak Crossing, out rural. We're going to head to IPI, 13 minutes to scene, and there's specialist centres there. Not that we are going to be going to a PCI stroke or trauma centre for this, I would hope. Who knows though. Onset 20 minutes ago. This caller info is a little bit wrong sometimes. So anyway, we'll acknowledge it and we'll get on the way. So once you acknowledge a case, you get your general appearance, your scene survey sort of thing, windscreen survey, that sort of jazz. So it's a suburban street, single story residential dwelling, clear access to the front door, scene is safe, no visible hazards or bystanders, single patient sitting upright in the living room sofa. Patient appears pale but conscious, tracking the crew's arrival. No obvious injuries or resp distress. So we are in the tutorial, so it's saying that we should introduce ourselves to the patient. The scenario will describe general appearance, which you've got above there, and you can ask for more detail. So in this case, if this was a normal case, we could chuck in there, can I have a general appearance of my patient or anything like that. It is exactly like an OSCE. It's exactly like you're talking to an assessor, facilitator. So if you type in there, can I get a general appearance of my patient before you even talk to them, that's perfectly fine. They'll give you a bit more information, say, pale, sweaty, vomitous around the mouth, yuck, all that sort of jazz. Being the tutorial, it actually pre-populates our first one. So basically doing an introduction. So we hit the button, and that's us talking there. Hi there, I'm a paramedic. I understand you've not been feeling well. Can you tell me what's been going on? The patient, sitting upright, making eye contact, says, I've just been so sick since around 7 this morning. I can't stop throwing up. Skin appears dry. No signs of active emesis at the moment. Interactions calm and cooperative. So we want to assess them. First thing we want to do is get some vitals. So we hit our vitals monitor. We hit our assessments. We hit our vital signs survey. That's going to pop it up here. You can't really see it. We'll minimize that for a second. We're going to check that. Basically, when something appears in here, it's going to happen next time we click the send button. So again, it's populating our words for us. So partner, can you start doing some obs, please? Whoops. Undo. And then talking to the patient. So how long have you been feeling nauseous? Have you vomited much? Any tummy pain or diarrhea? You can put as much or as little in there as you want. Obviously, you want to try and stimulate conversation with the patient, but you don't want to overload things, particularly when you're talking to AI and not real. So we'll send that, and then that will get our monitor set up here. So I can see we've got a heart rate of 72, 120 on 80 blood pressure, setting at 99%, respirator 14, temper 36.8, and BGL is 5.2. Beautiful. And we've got a normal sinus rhythm. We will have an ECG back in here soon. It's been behaving really strange. So if we wanted to, we can go back in here and get that out of the way. And we can do things like our sampled or our pain assessment or our head to toe. These things are just tools to guide you. So if you're a first year student or something and you're practicing your sample or your OPQRST, hit that. It's going to give you the little card. So let's just minimize him. It'll give you your little history card there. So it's more of a memory thing. It doesn't do anything by actually putting this in the queue or using it. It's just a memory thing. So if you're talking to the patient, you can flick this up and be like, yep, I've checked these, I've checked these, I've checked these, I've checked my medical history, I've checked last meal, and I've checked events. It's just a prompt. Doesn't actually do anything. I think it does affect doesn't affect your score, but obviously if you've done all that, you know you're going to get the best score. Now, if you're doing an OSCE in real life, you want to try and tick all those boxes because that's going to get you your best score. Anyway, Brian is my partner in this. I set that up. You can set that in the preferences. Excuse me, I've got the sniffles. I've got the kids are sleeping in weird spots at the moment. They're just outside the door, so I'm a little bit quiet as well. Lots going on. Brian applies monitoring equipment. Patient remains cooperative. I don't know why we're so focused on that. Says, I've been feeling sick for about 12 hours, vomited maybe 5 or 6 times since this morning. No real pain, just that gross nauseous feeling. I've had the runs a couple of times too. Abdomen appears flat, no visible distension or guarding. Now, back to our... so yeah, as it says here, you can gather all the same information through chat. You're just using those cards to structure. So we're going to screen for red flags. So thinking about nausea and vomiting, we want to think about blood in the vomiting, fever, chills, pregnancy, severe pain, recent travel. So this time it's not going to give us what we want to do. We're going to do it ourselves. So vomits, normal. What did he say? So now, again, you don't need to, it's a computer, but I always like to treat a patient, same as in an OSCE, I like to treat the dummy as if it's a person. So we're going to say that's no good at all. Now we're being prompted because we're in the tutorial. There you go, saying that he's probably got gastro. He had a shitty burger last night. No blood at all. That's been what I've been trying to eat or drink. No fever shakes for a week. Now look, we have not done thorough assessments here. We haven't done, we haven't palpated the abdo. We haven't done a real head to toe. We haven't done neuro or anything like that. But for the purpose of the tutorial, we're going to go through and give some Ondans. So you can either scroll down in here, big list of all the drugs we carry in Queensland at least. And we're going to go Ondansetron. Before giving them, we need to ask about allergies and contraindications. For Ondans, we need to think about allergies and prolonged QT syndrome. Now, we do also need to consider pregnancy. We haven't actually established if our patient is a male or a female, so that's probably another thing. When we walk in, we could go, hey, I'm Ben, what's your name? Just like in real life. So, So again, I'm just quickly going through. I've heard of it, never taken it. If it helps in it, I'm interested. Patient confirms no allergies to Ondansetron or similar medications. Great. Cool. Alright, so we have covered off on our indications is severe vomiting, which they're claiming they had. We're not contraindicated because we've considered the long QT and the pregnancy and the allergy. We're going to give PO, so we're going to give the orally disintegrating tablet. You can also do an IM or an IV. I don't know if you can do Ondansetron IM. I'll have to double check that. Yes, of course you can. Of course you can. Silly. But yes, so you've got IM there as well. We don't have IV at the moment because we haven't established IV access. That'll be in the chest pain video. And we've drug checked. So this is our drug label. We're going to drug check. We've got the 4 milligram tablet, which it's an ODT, but that's fine. Ondansetron, expiry 06/2027. So we're happy with that. We confirm it. We're just going to give 4 milligrams. So 1 ODT. And we're going to administer that. So it pops in down here. And then it'll go with the next second. Cool. So I don't know why it says 1 milligram PO. I go 4. It seems to know. So yeah, we've done our treatment there. All the vitals are very good. So we close that tutorial, but done our safety checks. And we did that. I'm going to skip that. Normally you just do it. Give administration. Oh, look, it even types it out for us. I forgot about that. Skip that. So now we're going to talk about our planning. On a job, you'd probably do this before you gave any sort of treatment, but look, for the sake of the tutorial, we need to actually give the treatment. So look. Oh. Here we go. Zing from your burger. You can so look, this takes long messages. We'll just hit that in there. So I've just basically said your vitals are all stable within very normal limits. It does sound like you've got gastro or food poisoning from the burger last night. I don't really think you need to be coming up to hospital, but happy to head up there and do some more investigation if you'd like. Otherwise, happy if you want to follow up with your GP, give us a call back if you get any worse or anything. So patient states, I feel much better knowing my vitals are normal, having that medicine. I'd rather stay here. Agrees to follow up with their GP. Understanding of recontact. And look, we should be saying that, but obviously being the AI, it tries to shortcut, a 10-minute conversation into 1 or 2 messages. So patient remains alert, stable. So now we're going to do our disposition. So we have, we'll skip that. we've got a couple of options there. Disposition, we can always request assistance, not that we need a CCP in this case or anything like that. We can contact CHUB or Clinical Hub or consult with like HARU, for those in Queensland, the High Acuity Response Unit. We can transport to hospital. We can do a roll form, hopefully not in this case. Patient refusing against medical advice is going to prompt a VERCA. Transport by private means, again, it's probably, they're going to go up to hospital anyway. Not required following assessment is probably going to be our case here. So it creates a little card. We hit that and it gives us some clinical justification. So it's just like doing a bit of clinical documentation. Gastro. So again, just some brief notes, cue that in there. And then again, we're just going to, it sends with a chat message. So and we'll send that. So this should popped up with our, don't need to worry about the wellbeing check-in. Pops in with our scorecard, which for some reason I've got quite a low score, but that's fine. It picked up the 1 milligram. I'll double check that, but yes, I'm pretty sure I gave 4. It should have been 4. And again, we use the QAS drug therapy protocols at the moment. I will get all of the other states in there over the next couple of months. Appropriate contra check, very good. It's interesting. The pregnancy is actually cleft lip defects in the first trimester, but that's fine. Non-transport appropriateness, that's all very good. Built rapport, gave options. We scored well for communication. 18 to 25, we did a logical windscreen survey. It comes up anyway. Primary survey, secondary surveys. We linked everything to the burger. We didn't explicitly document. We kind of did, but that's fine. Oh, sorry. It's been a long day. Medication error in the dose. I still don't believe that happened. No age and weight confirmation. Look, we didn't really get an age, so yes, we probably should have confirmed that. We also should have confirmed male or female, because I didn't. So it's given us some key learning points: DTP adherence, gastro assessment. Again, we didn't palpation guard, rigidity, and things like that. We should have done that. Non-pet transport, and we didn't do social supports or anything like that. So at the end of the case, it's given the opportunity to do some reflective practice. You can skip it. You can just go down to close report. So clinical turning point, the patient is stable at all times. They did not require hospitalization. Communication done well. What would I change? I would palpate patient's abdomen and be more thorough in my assessments. Complete all assessments thoroughly. So then you submit reflection. What that does is that then just goes off and saves it in your history. You can post the case to the community's feed. Oh, it also generate some feedback based on your reflection. So it's great to see you identifying importance of thorough physical assessment when a patient is clinically stable, correctly pinpointed effective communication, blah, 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 blah. So this just is like a two-way street for feedback. We can basically give out what we thought of the case and then get a little bit more consolidation from a clinical educator. Cool. Anyway, if there is an issue that you've identified in there somewhere, whether it's with the feedback or whatever, you can flag for manual review. And when you close it, it will go off to my dashboard. And I will manually review it and look through some quality peer-reviewed evidence and things like that to determine whether the AI needs some more fine-tuning or some more training, things like that. Make sure it's adhering to documentation and stuff like that. So you do also get some feedback. If you've submitted one for manual review, you'll either get an email or an app notification next time you log in after I've reviewed it saying, yeah, thanks, I've done that, or yeah, whatever the case may be. So anyway, I hope you've enjoyed. That's just a real quick run through of that basic case. I'll jump in and do the chest pain one shortly, and thanks for your time.